Fadi? Thank you very much, Fadi, for this wonderful video. So I would like to request Dr. Khalid to introduce our next speaker, Dr. Daniel.
Okay, good afternoon, everybody. It's my pleasure to be a moderator in this excellent session of the chronic lung disease, summarizing and tackling the chronic lung disease or the bronchopulmonary dysplasia from different aspects. I would like to thank Dr. Rajiv, whom I know for the last at least 15 years. And really, I congratulate him for this nice gathering and for his perseverance in making everything that he used to do in an excellent way. It's my pleasure now to introduce a dear colleague, Professor Daniel De Luca, who is the President-elect of the European Society of Pediatric and Neonatal Intensive Care and Professor of Pediatric and Chief of the Division of the Pediatrics and Neonatal Critical Care at Paris. Calais University Hospital, and he is the editor of the European Journal of Pediatric and WHO consultant. Professor De Luca will be speaking about the treatment of infant with severe chronic lung disease or BPD. Welcome, Dr. De Luca.
So thank you very much, Khalid. Thank you everyone for being here. It's a pleasure. I don't know in person. I hope to do that very soon in person in Dubai. Let me just share my slides. I think you see my slides, right?
Yes, doctor.
Okay, so thank you very much again. And in the next half an hour, more or less, I will try to speak about the treatment of these infants, so those with the more severe BPD. And I'm afraid that some of the things that I will tell you will be more or less overlapping with those that have been treated by beautiful speakers before me, like Dr. Banhari or Dr. Bancalari. Anyway, I'll try my best. And I also will give you a little bit of our local cookbook. I mean, what we do actually in Paris for these babies. So first of all, let me see. I want you to remember that the situation is very much complex. BPD is supposed to be a dichotomous outcome, but this is not true. We decided to code BPD at 36 weeks, but this is an artifact somehow. And in fact, as you may see here, the International Neonatal Consortium, where Eduardo and I also participated, actually recognized that the BPD is an evolving process, and it's something that is starting from the birth, even before the birth, and then evolves, and then even beyond 36 weeks, even beyond 40 weeks, you can have signs, as well as you can have signs very early before reaching the 36 weeks time point. So this full time point is now called CPIP, meaning chronic pulmonary insufficiency prematurity, as you may see from this consensus statement from INC. And that's extremely important because when we talk about severe BPD, we have to talk also about those that are evolving towards a severe BPD. So those that are actually having a CPIP that is evolving towards a more severe clinical picture. This also means that our interventions, as you may see here with all these arrows, may take place at different time points. They may be pretty early, or they may be anyway before the 36 weeks or later. So first of all, let's have a look at what you don't have to do to avoid severe BPD. So what you don't have to do is, first of all, intubate the baby in the delivery room. I know this is a little bit easy and may seem silly, but that's the reality. This is the meta-analysis from George Smalls in 2013. As you may see clearly that the CPAP, well delivered in the delivery room, is going to reduce BPD and mortality with a number needed to treat of 1/25. I will get back to that later. But I can tell you that it's really the reality, and it's really the main stem for the prevention of BPD, especially the old BPD, as Eduardo said 1 hour ago. We started to avoid neonatal intubation in the delivery room in Italy, like in 1997, 1998, so well before that. And I can tell you that this is true. The trend is absolutely correct, and that's the first main stem to do. Then there is another point. Even though you avoid intubation and you have a very well delivered CPAP with the right interface and with the right type of CPAP, and we could talk about that for quite a long time, sometimes you need surfactant. And what is really important, as you may see here from this Cochrane meta-analysis, is that surfactant should be given very early in order to reduce mortality and BPD. And very early means, as you may see, in the first 3 hours of life. So 3 hours may seem a long time, but actually it's not. 3 hours is very quick period. and you have to do many, many things in 3 hours. And you also have to decide if you can stay and play in CPAP, or you gotta go for surfactant administration. Doesn't matter if you use Insure, Lisa, or whatever you wanna use it. So that's a real picture from our NICU. And this is our local cookbook. So every time you see a blue slide, it's just because this is not gospel, it's just how do we do things in Paris. So basically we start variable flow CPAP with nasal mask from the delivery room at 6 centimeters of water. The NIC is very close to the delivery suit. And then we have a protocol that is called golden hour protocol. And in the first hour of life, these babies are only submitted to a UVC placement, starting TPN and caffeine, the first bolus of caffeine. And then we do our lung ultrasound score to decide if we can stay in plain CPAP or if we gotta go for surfactant administration with a threshold of lung ultrasound score of 8. And then we get surfactant with Insure, and then again, non-invasive support with a minimum 8 centimeters of water of minimum weight pressure. So that's the basic for everyone. So now let's have a look at what you may want to add in order to prevent or treat severe BPD. And I say prevent or treat depending on the time point when you start these additional interventions. It may be a sort of a prophylaxis if you are before 36 weeks in that time window of early chronic pulmonary insufficiency and prematurity, or it can be a treatment if this is later on. We also have to admit that we don't have so many treatments. Unfortunately, we are a little bit disarmed against BPD still, hopefully not for so long. I will tell you something about that by the end of my presentation. So here you see a small list of what may be the pharmacological weapon against severe BPD. Inositol is in gray because this has been tried up to a phase 2 trial. May seem interesting, but we absolutely don't have any phase 3 trial, so we cannot use it. And IGF-1, the insulin growth factor number 1, which is very much promising, is now under advanced investigation with a very large multi-center international phase 3 randomized control trial. I'm sure you have heard of it, and I will tell you something about it later on. So let's start from the non-invasive ventilatory policy. That's very much the main stem of this part. Exactly the same way, avoiding intubation in the delivery room and giving the right CPAP and giving surfactant early was the cornerstone of this side of the history. So this is our protocol. This is our local cookbook in Paris, and this is what we do for these babies. So as I told you, when a baby got its Insure, after the Insure is placed under CPAP or biphasic CPAP anyway, with a minimum weight pressure of at least 8 centimeters of water. And this is because that a little bit higher minimum weight pressure level is demonstrated to reduce the extubation failure and improve oxygenation and surfactant diffusion. And I want you also to remember the beautiful trial published by Eduardo's group in Journal of Pediatrics 2015, if I can recall correctly. But then sometimes something went wrong. It may happen, and a baby who was on CPAP at 8 centimeters of water cannot stay in CPAP because you see that it's deteriorating somehow during his trip. And I'm talking especially about the extremely low birth weight infants, those below 30 weeks or below 28 weeks or more or less. So you may face two situations. You may face a situation with an increasing work of breathing, so a Silverman score that is going higher and higher, and an increasing oxygen requirement to achieve a good saturation between 90 and 95%. So in this case, we are here in the blue line. What we do is to shift the baby from the CPAP to a real non-invasive ventilation that we usually provide with NEVA in order to have a perfect synchronization, a discharge, work of breathing, and also a good comfort from the baby. If we do not have enough NEVA machines available, because unfortunately we have 40 beds and we do not have 40 NEVA machines, we try to do the non-invasive positive pressure ventilation, but synchronized with flow sensor or a pressure sensor. Usually this is something that is nicely working. Sometimes if this is not working, our rescue therapy in this case, just because we really do not want to intubate again these babies, it's nasal high frequency arterial ventilation with a physiological approach with an increase in the minimum pressure under NHFOV, which is exactly the same alveolar recruitment approach that we are used to use and is very much known in endotracheal, in invasive HFOV, as the Anton van Gram group described it for the first time almost 20 years ago in the Blue Journal. Then there is another situation, because you may face a baby here that is deteriorating in an even worse way, and it not only has an increasing workup breathing or oxygen requirement, but also respiratory acidosis with increasing hypercarbia. Well, in that case, we go directly for an HFOV because of the high power of an HFOV to wash out CO2, both from the upper airway dead space and eventually also from the alveolar tissue. Usually this phase is gonna last a couple of days, 2, 3, 4 days, and you should have an answer. And then, according to the baby situation, you can go back directly to the CPAP, more or less to the same pressure level, or you will need to continue with non-invasive ventilation, and so to go to the other arm here. I have to admit that it's complex and it requires the knowledge of many ventilatory techniques, but especially requires a good nursing. Nursing is extremely important in these babies, and especially when one of these babies is under this unstable situation. Those babies are also monitored over time very closely, are considered to be a very high risk. And we do a sort of a multimodal non-invasive monitoring with the lung ultrasound, which is done more or less every 3-4 days, transcutaneous blood gas, and some scores for the comfort evaluation and above the saturation and perfusion index. So those are some pictures of the real life of babies that were under NAVA non-invasive ventilation, as you may see here. And here on the right, you can see a video. One of these babies that was actually before being placed on NAVA was under 50% of oxygen to saturate 90% with a pretty bad workup breathing. And then you can see him very quiet and nicely placed in the mother's arm without any problem, and with an oxygen more or less in room air without any big deal. So basically, the principle of NEVA is that you are there to achieve a sort of a compromise, and so to avoid the high workup breathing that is characterized by rapid shallow breathing and a high peak of electrical diaphragmatic activity, which are the electrical counterpart of this workup breathing and a high Silverman score. Or from the other side, you want to avoid a too much higher mean airway pressure, and so a trend to a flat electrical activity of the diaphragm, which means overcompensation. So by monitoring the electrical activity of the diaphragm, you can actually see what is the best compromise, which is achieved with very variable breathing pattern at the electrical activity of the diaphragm, a nice PaCO2, and a pretty low Silverman score. And this is usually achieved with significantly lower peak pressures compared to the conventional non-invasive ventilation, and also with usually a lower FiO2 compared to the, let's say, conventional non-invasive ventilation. So this is an example of some electrical activity of the diaphragm tracing from the very first work published by Jennifer Beck in Montreal at that time with the NAVA prototype. I want you to try to guess which one of these babies is actually sick and what are conversely those that are not sick. So I can tell you that those are all preterm babies, but none of them was actually very sick. Surely here you can see a neural apnea, central apnea. You see the tracing is flat. Here you can see a sick, a very big inspiratory effort. But basically, all these babies were completely normal. So this means that their breathing pattern was extremely regular, extremely different from one from the other, even erratic, if I can say so. And this justifies why it's so hard to synchronize non-invasive ventilation in an extremely low birth weight infants if you don't have NEVA technology. So that's a lot of data about NEVA that I'm not going to mention here today, but just wanted to tell you that according to our experience, even when you have an established severe BPD and you got a viral respiratory infection like flu or like RSV bronchiolitis, NEVA is able to improve the situation. So this was a controlled study that we did a few years ago in Italy. And you see these babies with bronchopulmonary dysplasia recovering from RDS induced by bronchiolitis. So mechanically speaking, that's the worst situation of ever. It's a nightmare because we have a mixed pattern. This is restrictive and also obstructive. Well, then these babies randomized to a pressure support ventilation or NEVA ventilation are showing all the better parameters in the NEVA group. For example, you see the comfort in terms of heart rate and pressures and the oxygenation, and no surprise, like any other NEVA studies, a lower peak pressure to achieve the same ventilation. And what is more important, the comfort was better in the NEVA group, and the duration of mechanical ventilation was shorter in the NEVA group. But there is one study I really want to show you because it's one of the more recent, and it's also one of the funnest I ever remember. So these guys, they use NEVA non-invasively in these babies with evolving BPD, and they place a very highly sensitive microphone in the incubators. And then they place another one in the baby's chamber, okay? And they did the comparison with babies under classical non-invasive positive pressure ventilation. So there is no surprise in knowing that babies with NEVA have a lower peak inspiratory pressure or FiO2 or CO2 or something. What is really funny and is really interesting is that according to the microphone recording, babies under NEVA had significantly lower movements and significantly need to have the caretaker entering into the chamber or opening the incubator. So basically, they had less events, they were more comfortable, and the nurses had less need to take care of them. So clearly, this is not going to reduce severe BPD, but it's also something that we have to remember on top of the advantages of this technique. So now, how we can recognize that BPD is going to become severe, or even better, a CPAP, a chronic pulmonary insufficiency prematurity, is going towards a severe BPD. So one of the tools that we have right now is lung ultrasound. So this has just been published from my group in the Blue Journal. And you see, this is the lung ultrasound score in extremely low birth weight infants that are going to develop BPD here on the top, and those that are not going to develop BPD. So you can see that at any time point from day 0 up to 36 weeks, this was a very longitudinal study, the lung ultrasound score is always lower in babies not developing BPD, which means that they have a better lung aeration, and they have a greater lung volume. And particularly around 1 week and 2 weeks of age, there is a peak in lung ultrasound score that is observed. And no surprise, something like that has been reported also in other studies from Spain, namely, and also very recently from Italy. There is a multi-center study from Raimondi group and others who got published in Pediatrics. So these are very much consistent data. And here I can give you some example of one of these babies just spotted 14 days of postnatal age with a very high lung ultrasound score and a high oxygen requirement. And here you see the picture, a very bad consolidation. This is just one picture, but I can show you it was more or less the same all around the chest from both sides. So this baby had a 15 on lung ultrasound score, 12 of oxygenation index, was a little bit on respiratory acidosis, as you may see here, and he even had a bit of pulmonary hypertension that started to be evident at that point in time. And I want you to recall also beautiful data published by Stephen Abban a few years ago demonstrated that if these babies have, let's say, an onset of pulmonary hypertension between the first and the second week of life, that's unfortunately a significant risk factor for severe BPD later on. So facing one of these clinical pictures, you may decide to intubate or not. We do not want to intubate these babies, and so we use non-invasive ventilation, as I told you, but we also use nebulized iloprost, which is a potent pulmonary vasodilator, very much suitable and easy to use, much more than nitric oxide in non-invasive ventilation, which is very much effective in this case. As you may see here, we published our experience a few years ago. And you can clearly see the improvement in infant heart rate and respiratory rate starting NAVA, non-invasive ventilation, and iloprost later on. But especially you can see here the improvement in oxygenation on the left side of the cartoon, and the hemodynamic improvement in terms of the ratio between pulmonary and systemic pressure on the right side of the cartoon, thanks to nebulized iloprost during NEVA or during NHFOV anyway. So it's not just about that, because clearly it's really multifactorial, but I want to show you the data from my NICU before we started all this job, so 2012, before I was appointed there in Paris, with the data that we have right now. So babies below 32 weeks gestation, according to the classical NACHD BPD definition issued by Eduardo and Alan Job, now have a rate of BPD of more or less 6%. And we had a more than 15% in 2012. And no surprise, although these numbers are a little bit, well, are higher, surely when you just look at the babies below 28 weeks, still there is a very significant trend. So let's talk about the drugs. Basically, we have 3 drugs to remember here after the ventilatory policy. We have the vitamin A, caffeine, and the CPAP, if I can call it as a drug. So if you look at the number needed to treat, you will see that the vitamin A and the caffeine seem to be much more effective than the elective CPAP. But well, you have to recognize that CPAP is anyway unavoidable, also because these babies need a little bit of support to reducing the work of breathing, and because of the effect of CPAP on apneas of prematurity. And I want you to have a look at this number needed to treat with a different point of view. And it's very nice to see this paper recently published by Jensen and Barbara Schmidt and co-worker, where you can see the evolution of number needed to treat according to the incidence of that particular outcome in a particular setting, which is very much important. For example, you see here, number needed to treat for vitamin A was supposed to be 13, okay, at the level of the meta-analysis or the trial that first described this, this benefit. But if you go down with the advent of BPD to more or less 20 or 17%, okay, you see that the number needed to treat will be much higher. Okay, so this is something you have to remember in order to decide if you want to use that particular approach in your NICU or not. We personally use both caffeine and vitamin A, but it's also possible, for example, that the effect of vitamin A was just tiny in our low BPD incident setting. I'll tell you something about that later on. So let's have a look at the BPD physiopathology to understand how these different drugs may work. Unfortunately, BPD is very much multifactorial and multifaceted. For example, you may see that there is a surfactant injury, okay, because of the abnormal postnatal lung development and because of the inflammation given by oxygen, ventilation, and infections, and other, unfortunately, many other triggers that are coming from postnatally. Ventilation is also inducing an inhibition or a maldevelopment of vascularization that may in its turn involve a metabolic alteration locally. Vitamin A can be somehow useful to revert this, let's say, wrong alveolarization, trying to promote a good alveolarization. CPAP and caffeine can somehow promote a good, let's say, lung volume opening, avoiding the use of invasive ventilation. And especially, we have to remember that when we look at the alveolarization, when we look more in general at the lung development, we have to remember that there is a very first stage that is depending on the growth factor from the mesoderma. And then there is the last stage, much more on the alveolar side, that is actually depending on TTF1 or NKX1 gene. So this gene is a nomeo gene that is very much important for the alveolarization. And you know better than me that its depletion or anyway its deficiency or mutation are very often not compatible with life. But what is very much interesting is that that particular gene is controlled in its transduction by retinoic acid, so by vitamin A. So this is why vitamin A is important for the alveolarization, and it's so far, unfortunately, the only drug able to do something in this very much important biological process. And no surprise, if you look at the data, this is coming from Spears in American Journal of Clinical Nutrition some years ago, but it's still very much interesting. Those very low birth weight babies with a retinol concentration in plasma less than a given level have an odds ratio to develop bronchopulmonary dysplasia extremely higher, 3.5. So this means 350 times higher than babies with a good plasmatic retinal concentration. And this is exactly why some studies in the past have examined the use of vitamin A. I recognize this is a pretty old meta-analysis, but this is what we have. You see the diamond is on the left. So there is a significant, although small, reduction of BPD with vitamin A. We are more or less around 10, 15% in terms of reduction of mortality and or chronic lung disease and or just the chronic lung disease, as you may see here. Some more recent meta-analyses have been released, as you may see here. There's a couple of studies more, but everything comes to the same conclusion. You see again, the diamond is on the left for BPD. Well, I don't know how much value we should give to the NICU stay, which is such a, multi-faceted and flu outcome, but for BPD, the data are very much consistent. So some may be worried about the use of vitamin A intramuscularly. Personally, I'm not, and we use it because I suppose that the damage done by an intramuscular injection is much less than the damage of developing severe BPD. And anyway, we use intramuscular injection with EMLA to reduce the baby and sucrose clearly to reduce the baby's pain. But in order to avoid even this small side effect, there are a couple of trials ongoing around the world. This is the VITA trial in the UK, which is randomizing babies to receive high dose of oral vitamin A, as you may see here. This is still ongoing, and we hope to see we hope to see the results very soon. And then there is another one you probably guys are more aware than me, to which Jane Pillow contributed, and this is also ongoing with more or less the same design. So basically what we do here, well, we give vitamin A, 15,000 units, one shot per week, every single week, in babies below 28 weeks of age, if they're still oxygen dependent, or they are intubated, or they are a very high risk or very high BPD risk at the third day of life, which represent exactly the same criteria used in the meta-analysis demonstrating a certain benefit of vitamin A for BPD. So let's see about caffeine. So caffeine is probably the oldest drug in this context. I want you to remember the wonderful CAP trial published by Barbara Schmidt in New England Journal of Medicine 2006. That trial was not originally designed for BPD, but as you may see here, BPD was extremely and significantly reduced in the arm receiving caffeine as compared to placebo. So this was maybe a little bit of surprise, but it's very much useful. Anyway, we should have given somehow caffeine for the prevention and treatment of apneas of prematurity. So we have one more important reason, and this is why we give caffeine from the first hours of life, as I told you. This is really the first thing that babies receive in the first hour of life together with TPN, up to 36 weeks gestation. But why we do so? Because time matters. Time matters. And so we can argue that the earlier caffeine is administered, and while the better will be its effect. And in fact, one of the reasons why caffeine may be working in that is that, as we know, caffeine has a significant diuretic effect. So as you may see here from these curves in the CAP trial, babies receiving caffeine clearly had a mean weight change more important compared to placebo, meaning that they lost weight more quickly in the first week of life compared to the placebo babies, and then they still had a lower weight compared to the placebo arm. So this is why the time matters, and this is why we have to start caffeine as soon as possible. There are a few meta-analyses that have been published later on. This is one from Korea, only taking into consideration retrospective studies, so not RCTs. But again, all the data come to the same conclusion. You see the diamond is on the left, so this is in favor of reduction of BPD and or BPD and mortality as a composite outcome for babies receiving BPD, from babies receiving caffeine, as I told you. And then there are also other effects, other positive effects that have been shown by this beautiful work of Peter Davis. And again, you see the diamond is always on the left, also for disabilities and for cognitive delay and even PDA, surgical ligation, and so on. So really no reason not to use caffeine for these babies. But if you want to have more insights in terms of pathobiology, here you have an example of an animal model when the lung has been injured with hyperoxia, and you clearly can see the effect of caffeine compared to animals receiving placebo or receiving saline as placebo. But this is just an example. There are many studies of this type. So what we do in Paris for that, we give a 20 milligram per kilo bolus of caffeine in the very first hour of life, as I told you. And then we continue 5 milligram per kilo up to 36 weeks post-conception age. According to the apnea, we may want to increase the daily dose to a 7.5 or 10 according to the situation, and is weekly adjusted to the weight gain. If the baby is not receiving any insure because he or she has a very severe respiratory disease, so it's getting a longer ventilation, we also do a 10 milligram per kilo, a small bolus pre-extubation. From time to time, but it's very seldom, we check the caffeine serum level, and we had a look at some normative data for those that have or not have received extra boluses that you may find here in this publication that I show here in this slide. What about steroids? So the great hope would have been the nebulized steroids, because you know better than me that unfortunately IV steroids to somehow treat or prevent evolving severe BPD are not free from side effects. Well, unfortunately, I believe that we can say the last word about nebulized steroids. There is such a meta-analysis that you may see here demonstrating no effect of budesonide, but also you may want to know that this absence of effect is probably due to a lot of reasons, notably the lung deposition, which is extremely variable, low, and dramatically affected by the lung injury, by the type of ventilation, and also by the type of nebulization, as you may see in this animal model. And again, there are many other studies. I just mentioned this one because it's from France. You will forgive me. And after all that, we also have to look at the neurosis trial, which has been really the very last trial on nebulized budesonide. And here again, unfortunately, no effect, no benefits in terms of BPD. And even if you look at the component of primary outcome subdivided between them, and so particularly you look at survival free from bronchopulmonary dysplasia, there's a pretty bad surprise, because that survival is going to be lower, significantly lower in the budesonide group compared to placebo. I have no particular explanation for that, but surely this is not something that is warming me up to use every day in my activity, nebulized budesonide. We could have talked about the intratracheal budesonide and mixed it with surfactant. Not having much time for that, but this is surely something interesting, because by this way, at least, we are sure that budesonide is getting there exactly where we want it, so in the alveoli. And since budesonide is sort of a sterolic molecule, it can be very much liposoluble into surfactant. You know better than me that there are studies done in Taiwan by Dr. Ye and co-workers. There is a hard rationale behind the use of budesonide in this setting, but I also want you to remember that in the Taiwanese studies, the starting point of BPD incidence was 50–60%. So it's extremely higher BPD incidence, probably induced by a lot of inflammation due to mechanical ventilation. We cannot actually extrapolate these data and think that there is exactly the same effect in a NICU or in a setting when there is a lot of non-invasive ventilation and so a lot of less inflammation in these babies. So still IV late postnatal steroids are there, and sometimes, although very rarely, may be used. It happens very rarely, but what we know is that they can be used only after 7 or 14 days of life. This is nothing new. You can see this meta-analysis again demonstrating the reduction of BPD when you use them. But again, if you look at the date of these studies, no surprise, these are very much enrolling. These were very much enrolling babies, different from what we have right now. Not because they didn't have any NEVA, but also because they had much less prenatal steroids, much less non-invasive ventilation as a rule, and a different concept of neonatal care in general. And this is exactly why, to give you our local cookbook in Paris, by using our protocol on non-invasive ventilation, I can tell you that the need for intravenous steroids almost disappeared. It happens to use intravenous steroid to extubate somebody who has been stuck in on a ventilator more or less once or twice per year in my unit. So the big question for you is, do we go for low dose dexamethasone or do we go for hydrocortisone when we really have to use intravenous steroids? So this looks like, you know, a little bit US versus Europe. Low dose dexamethasone is something very much American, like hydrocortisone seems very much EU based. I have no suggestion, I have no clue about that. I personally believe that both of them are safe. So also dexamethasone can be safe if it's very low dose, but you have to pay attention to the higher dose because as you may see here from this beautiful paper from Arialde, clearly the higher dose of dexamethasone are associated to a lot of side effects that you know better than me, while we know because of all the studies done, especially in the Netherlands, that hydrocortisone is very much safe. And you may see here from this one from 2015, absolutely no risk in terms of disabilities or cognitive delay or other neurological abnormalities in babies who have received hydrocortisone. You probably know better than me that there are 2 trials that actually showed the use of hydrocortisone very early, even for extubation in the first 72 hours of life. One of them is the Premiloc study has been done in Paris, not in my unit, but in France anyway, demonstrating an effect, a positive effect of very early hydrocortisone. The other one is the STOP BPD trial driven by Anton van Kam in the Netherlands and in Belgium, who did not demonstrate any benefit. So again, here, I want you to tell you to pay very much attention. The babies in the Premiloc trial, the one that demonstrated the benefit of hydrocortisone, were in more than 50% of cases stuck in on a ventilator on 72 hours of life. The babies in the non-BPD trial in Belgium and in the Netherlands were mostly under aggressive non-invasive ventilation. So again, that's a basic confounder. This is really a game changer. If you do an aggressive non-invasive ventilatory policy, your need to use steroids will be significantly reduced. And so the effect of these steroids may have. So this is the schedule of hydrocortisone that we rarely use. It's basically adapted from the Rademacher study protocol, nothing really new. And then to conclude, as I told you, there is the IGF one, the insulin growth factor one, which is, let's say, giving us a lot of hope, not only because it's on a phase 3 multi-center international randomized control trial, but also because in my mind, IGF-1 seems to be right now the only drug pro something, so pro alveolarization, so helping in developing normally a biological process. It's more or less what the vitamin A was supposed to do, but vitamin A does not do that very well. So far, we only have done something anti-BPD, like giving steroids to be anti-inflammatory. So using non-invasive ventilation to be anti-inflammatory somehow. And IGF-1 has the potential, at least theoretically, to promote a good alveolarization. So the trial is called Footprint, is now ongoing. We're participating in that, as many of you, I think, and we hope for the best for the future, although this is not free from complications and especially from a logistical and practical point of view, but we hope for the best and we will see. So thank you very much for having listening to me, and I'm very happy to take all your questions.
Dr. Khalid, your mic is mute.
Sorry. Thank you, De Luca, for this really nice, precise lecture about the BPD. And there is one question asking about what you do for those who don't meet your lung ultrasound score.
I cannot hear.
Your voice is very low, doctor.
I don't hear very well. I'm sorry. I didn't hear the question. The volume was very low. Can you repeat, or shall I read the questions on the chat?
Who is asking the question?
Dr. Khalid, your voice is not coming. So I think there is some audio problem from your end. So if Dr. Rajiv or Dr. Rajesh can take up the question, someone.
Okay, I'll take. Sorry, Dr. Khalid is there now. Is your mic on, Dr. Khalid?
Yeah, but there is some problem. We cannot hear, doctor.
Okay.
Yeah. So Dr. Rajesh, if you can take the question, what Dr. Khalid was asking.
No, I didn't hear the question. That's the problem. Okay, so I think there is a question. What would you do for those who do not meet your LUS score?
You mean at the birth or later on? So babies that at the birth have a lung ultrasound score lower than 8, they stay on CPAP, they don't get surfactant. They stay on CPAP and they go on very easily.
Okay.
Taufik,
Yes, doctor.
can you make me visible? Taufik, can you hear me?
Yeah.
Taufik?
Okay. Doctor. Just start your video.
Okay. Daniel, can you hear me?
Yeah, you're
Yeah,
it.
yeah,
I can hear you.
Yeah, Daniel, I wanted to ask you, what was your ventilatory strategy in babies with severe BPD? I wanted to ask you your ventilatory strategy.
But you mean when the BPD is already established and
Yeah.
but basically the ventilatory strategy is what I showed you in the slides. We use all this combination on an invasive ventilatory strategy. So we according to the physiopathological pattern, according to hypercarbia or hypoxia, we use NEVA non-invasively, or we use the non-invasive high frequency oscillator ventilation. In the rare cases that got intubated, but again, this is extremely rare, we are a more HFO NICU, so we use HFOV, paying attention to the tidal volume, well, to the stroke volume, and so on. But I don't think that this is very much important, because when you get there, the game is already lost.
Yeah.
It's not the ventilation there that is going to be very much helpful. You can ventilate them in HFO, you can ventilate them in volume guaranteeing conventional. This is absolutely fine, I think.
Yeah, hi, Dr. Daniel. Just another question. We see a lot of babies who have got chronic lung disease or BPD, and a lot of time we see PI changes with them with hyperinflation lungs. What would the best modality like ventilation strategy in these ones?
Best modality is to avoid this situation. Nothing more than this morning, I received some chest film from somebody from Italy with a baby like that was on the ventilator for 4 weeks, and that to me had already the criteria to be extubated like 20 or 25 days ago. So that's the real point. You don't have to get there, because once you get there and you have such a hyperinflation and you have a pulmonary interstitial emphysema, then the situation is very bad. You can try whatever you want, but there is no magic bullet. There are some of them that are going a little bit better with HFOV. Somebody use even the jet ventilation, but you don't have to get there. To be clear, even if rarely some of our babies can get intubated, we have 0 PIE. We don't have pulmonary emphysema, and it's just because we are extremely aggressive not to intubate them. The most important part is really the non-invasive ventilatory policy, not to get there.
Great. Yeah, I think I agree with that. Any other questions from any other panelists?
Daniel?
Yes, please.
can you share that your cookbook with us sometime later this week? Your procedures to prevent this is very
is exactly what I brought in the slides. You are more than happy, you're more than free to download the slides. I think I sent it to you, but I can send it to you in PDF as well, so you can use all the doses and the protocol for non-invasive ventilation. There's no problem.
Thank you very much. I think.
My pleasure.
Thank you. Any questions you can take?
There's another question there I see in the chat. Can you call it BPD if a preterm develops oxygen requirement and non-invasive ventilation X-ray changes? Again, on BPD at 4-5 weeks of birth with no history recorded pneumonitis requirement at birth. So that's interesting. So technically speaking, and Eduardo is much more versed than me in that, you give the diagnosis of BPD at 36 weeks, not before. But we know that BPD is an evolving process, right? So this is why the concept of chronic pulmonary insufficiency prematurity has been introduced. So clearly, if you have a baby at 4 or 5 weeks with increasing ventilator requirements, chest imaging that is not so good, this is not technically speaking BPD, but surely is evolving BPD. Surely is CPAP. So we have to take care of that, although it still does not qualify yet for BPD.
I think Patrick is also online, so if there's any question for him.
So after this lecture,
after Vinith's thing, Patrick will come.
Yeah.
So now, we'll go ahead for Dr. Bandari's question, last lecture.
Yeah, if you want to put me on, I've unmuted myself. You put my screen on, Tawfiq.
Yeah, you are all visible, doctor, and you can start your video and you can share your screen, doctor.
Okay.
So thank you very much, Daniel.
Okay. All right. So I'm going to start share my screen. Hopefully it'll come up. Okay, can everybody see my screen?
Yes, doctor.
Okay, great. Thank you so much so for all the people who are actually staying back for my last talk. So you already heard ventilation strategies, and now I'm going to be focusing on the non-ventilation part of BPD. Again, I think as you heard from Daniel also and from Eduardo, the focus is to try to get the tube out. That is really, really the most important thing that we can do to try to decrease inflammation in the lung and prevent the baby from getting into severe BPD. But there are other things, and you've heard Daniel talk about vitamin A and caffeine. And again, this will be a very practical talk. I'll give you doses when we start, when we stop, how we do it, as we go along, how I manage the fluids and things like that. For some of you who may not have joined me earlier on for my earlier talk, just to remind, when I talk about BPD, I still am using the clinical definition for most of my outcome measurements, which is assessment at 36 weeks post-menstrual age. And you have to have 28 days plus of requiring supplemental oxygen more than room air. And depending upon whether you're needing room air or you're needing positive pressure support, you will have mild, moderate, or severe BPD. This again is a repeat slide from my previous talk, but remind everybody once again that BPD is a multifactorial disease. It's genetic factors along with some environmental factors interacting with it, ventilator trauma, specifically invasive ventilator trauma, infection, pre or postnatal hyperoxia exposure on a bedrock of immature lung with or without RDS, leading to inflammation and cell death, which leads to lung injury. And here, in more detailed about what the new BPD looks like. So you have these factors mentioned above here, prenatal factors, hypertension in the mom, hypoxia, infection, smoking, genetic susceptibility, and the lack of steroids, mechanical ventilation leading to volute trauma, barrel trauma, and electrotrauma because releasing of these inflammatory markers and agents, hyperoxia causing damage by DNA, lipid peroxidation, and protein oxidation, again, releasing cytokines that can be damaging to the lung, which leads to aberrant tissue repair, and dysregulated vascular and alveolar development with the new BPD. So essentially, you can think of BPD as components of 4 different components. There is maternal factors, antenatal factors, infant predisposition, oxygen injury, and mechanical ventilation. So the effort is to try, and you can't do much about the genetic susceptibility, not yet anyway, but obviously there are the therapies, experimental therapies working on manipulating that. One can at least try to do something about the maternal factors. At least from our side, we can try to push for giving of antenatal steroids and try and prevent or decrease the mom from smoking. For mechanical ventilation, you've already heard my previous talk as well as Daniel's talk. So you know the effort is to try and get the baby to non-invasive support. And for oxygen injuries, to try to minimize the exposure to the high concentrations of oxygen. I think this is very, very important, and you always need to be very good friends with the maternal fetal medicine or your obstetric colleagues. And so whenever you come in the unit in the morning, I would highly recommend you go and say hello to them and just remind them, please give antenatal steroids to the babies who are threatening to deliver early. While this has not been shown to decrease BPD in multiple studies, however, it does decrease the severity of lung injury and lung disease in the early stages. And this might help you to get the baby onto non-invasive support, which eventually might make an impact on decreasing BPD, or at least the severity of BPD. So highly recommend. In the US, we are pretty much approaching almost 95 to 98% in the centers that really make a strong effort to try and use this. Oxygen use. This is the next drug, and it is a drug. So obviously, like any other drug, there are specific indications and specific side effects that you have to be aware of. And we start off from the delivery room. Our default strategy is using somewhere between 30 to 40% oxygen. Most of the time, we put the FiO2 setting at 0.3 for a preterm baby. We use CPAP in the DR, and sometimes we will also use NIPPV using the TPIS resuscitator. If we need to use blow-by oxygen, then we increase our FiO2 to 100%. But again, the effort is to try to give the oxygen through the blender and to try to not use beyond 30 to 40% initially if we can avoid. And again, keep in mind that the oxygen saturations at birth for the first 5 minutes, and there are Dawson curves from Australia that you can look at what oxygen saturation. So we try to aim for reaching an oxygen saturation of about 85% in about 5 minutes of life. So there is enough time, and we don't want to rush to increase the FiO2 very quickly soon after birth, because after all, the baby is deficient in antioxidants, and we do not want to expose the reactive oxygen species to this immature lung, which will obviously cause more damage and injury. So during the first few minutes of life, a saturation of 70 to 80% may be acceptable as long as the heart rate is increasing, baby is ventilating, and SpO2 is increasing. If the SpO2 is less than 85% at 5 minutes, then only we start increasing the FiO2 from 40% and beyond, and we deliver it through the blender. We usually increase it by about 10%. If the saturation is more than 93%, we will actually decrease the FiO2 right in the DR itself, just trying to maintain the saturation parameter somewhere in the 89 to 94% in the recommended range. And so our recommended target is 89 to 94%. We start doing that right from the DR, and we will then, when we move to the NICU, we will keep the alarm limits in our monitors at 88 to 95% for less than 34 weeks babies on supplemental oxygen. For babies who are more than 34 weeks, just supplemental oxygen or with ROP stages 2 to 3, where we are obviously concerned about pulmonary hypertension, we will increase our target to 93 to 97% with alarm limits of 92 to 98%. Drugs. So oxygen, again, once again, I want to remind everybody it's a drug. And so its main use is prevention of hypoxia or hypoxemia and as a pulmonary vasodilator. As I mentioned in my earlier talk, in the early and evolving phases, we will titrate the FiO2 to keep it around 89 to 94% and generally more than 88 and less than 96%. In the established phases, we use 93 to 97% for prevention management of pulmonary hypertension. Methylxanthines, you heard a lot about it from Danielle and also initially also from Eduardo. So keep in mind that caffeine is a very nice drug. It has a very large therapeutic to toxic ratio. In other words, you can use higher doses without getting too worried about the side effects of it. And so we routinely do not measure levels, as you already heard from Daniel, and we tend to use it early, and we tend to use it for a longer period of time. It's not only a direct respiratory stimulant, it decreases diaphragmatic contractility, it's a weak bronchodilator and a diuretic. So it has multiple actions, and so that's why we think it definitely seems to be associated and been proven to be shown to decrease BPD. And as a follow-up of the CAP trial, it also improves neurodevelopmental outcomes. So our dosing range is caffeine citrate 20 per kilo, loading dose, and 5 milligram per kilo maintenance dose. And we can go up to as high as 10, sometimes even up to 12 milligram per kilogram per day maintenance dose. There are side effects with feeding intolerance and tachycardia. That is by definition more than 180 per minute, which is consistent, but it is rarely seen, and we are able to maintain the baby on caffeine, and we find that it is helpful in keeping the baby out, keeping the baby away from the endotracheal tube. Vitamin A, you heard about the potential benefits of it. It helps in maintaining epithelial cell integrity of the respiratory tract. I think part of the reason why it has not really been that beneficial is that vitamin A levels in preterm babies is reflective of the maternal vitamin A status. And the original study by John Tyson, had a lot of population from the southern part of USA where there is maternal undernutrition or lack or levels or lower levels of vitamin A. And so the babies may have been deficient in vitamin A. And I think you saw a slide from Daniel where he talked about that it seems to be more beneficial where the baby has lower levels of vitamin A. So if you have normal or near normal levels of vitamin A, it does not really improve the respiratory epithelium. However, if there are deficient levels, then it does seem to help. And the dosing that is recommended based on the randomized trial is 5,000 international units. I am given 3 times per week for 4 weeks. It's starting at birth, but you heard a different regimen that Daniel uses. So you can think about using one or the other as per whatever the level of comfort is in your unit. Diuretics. Now, diuretics is essentially to decrease pulmonary edema. It's only transient improvement in lung function. It doesn't seem to prevent or decrease BPD, but at least in the first few weeks of life, we do find that we're able to decrease our requirement of the fluids, and also might be able to decrease the ventilator settings and FiO2 requirement to some extent. It might also be helpful in managing PDA-induced pulmonary edema. The drugs that we tend to use in the first couple of weeks of life tends to be furosemide, and the dose is 1 to 2 per kilo per day or every other day. In the chronic phase, mostly in the evolving in the established phases after 3 or 4 weeks of life, we tend to use chlorothiazide 20 to 40 per day, sometimes alone or sometimes with spironolactone, depending upon whether we want to add sodium chloride and potassium chloride to the supplements. It is very important to keep an eye on the electrolyte abnormalities. Keep in mind, long-term use of furosemide also leads to nephrocalcinosis and osteopenia of prematurity, as it is a calciuric drug. We tend to keep the sodium levels around 132 or more, because if you have sodium levels higher than that, you will tend to retain more water, which again makes you need to give more diuretics. But if you have lower levels of sodium, serum sodium of less than 132, your growth of the baby is going to get affected, because sodium is a very critical part of the sodium-potassium ATPase pump and very important for every cell in the body to be healthy. So it's a little bit of a fine balance of giving enough diuretics to keep the baby on the dry side, but also not giving too much of diuretics to make the baby having severe electrolyte abnormalities and the problems thereof. Bronchodilators. Now, bronchodilators obviously is meant to open the airways, but preterm babies may not respond to this very well, depending upon the amount of smooth muscle that they have. I pretty much restrict its use to evolving and established phases. The ones that I'm more comfortable using is the albuterol or salbutamol, and the dose is given over there. And there has been studies done that actually if you give it to an MDI with spacer, you will actually deliver more and have a better response. We actually did a randomized control trial showing that to be the case. And it is again effective treatment for reversible bronchospasm, although long-term use has yet to be established. I tend to use it in babies who are bigger, where I will try it and see if it makes a difference in terms of air entry before and after using it. And if it does help, then I will use the dose given Q8 3 times a day. The other one for muscarinic antagonist is apatropium bromide, and that again, using it with a nebulizer or MDI, the dose is given on the screen, can be used as adjuncts in patients who are significantly responsive to albuterol, who we are not responsive. So if you have a baby that is not responding well to albuterol, you could try that. It may be better tolerated than albuterol because in babies with bronchomalacia, apatropium, it does not create that kind of a potential bronchospasm in that situation. So that might be helpful in terms of also decreasing your secretions. These are some of the drugs that can be used. It is listed over here: albuterol, terbutaline, and the different trade names, preparations, and the doses that can be used for the anticholinergic agents, which may be used as an adjunct or in place of other. You can see the doses listed over there. These slides have been sent to Rajiv, and he can share them with you as time permits. Keep in mind that these drugs are helpful only in the short term, has not really been shown to make a difference, but in a particular baby, using this in adjunct with the other supportive therapy you may be giving might help you to decrease the ventilatory support that you are providing, and may in some situations even prevent the baby from getting intubated if you are already non-invasively supporting the baby. Postnatal steroid. Now, this is something that has been talked about, and again, it is meant to decrease inflammation and pulmonary edema. I tend to use dexamethasone and in the evolving phase, and this is mostly when I'm trying to extubate the baby. So you have, and I try my best to keep the baby extubated between 24 to 72 hours of life. And if they do get reintubated after that, then I will use diuretic for the first couple of weeks. And after about 3 to 4 postnatal weeks, if I still have a problem in getting the baby extubated, I would use the dexamethasone. The dosing is based on the DART trial. Usually within 48 hours, I'm able to get the vent settings down enough to try to get the baby extubated. And then I too obviously try my very best to keep the baby extubated. In the established phase, that means after 36 weeks of postmenstrual age, if you still have a baby who's on non-invasive support or even on, say, nasal cannula, something like that, and is on oxygen, prednisolone might be helpful. The regimen is given on your screen. Is 2 milligram per kilogram for 5 days, then 1 milligram per kilogram for 3 days, and then 1 milligram per kilogram every other day for 3 doses. And this has been shown it's a study published in Pediatrics, where it has been shown to be helpful in weaning oxygen and getting the baby off oxygen and potentially getting the baby home. The side effects of steroids, as you are well aware, include hyperglycemia and hypertension in the short term. In terms of other drugs, steroids that have been used, I want to mention a couple of studies, and this is the hydrocortisone study. It is a double-blind, placebo-controlled, multi-center randomized controlled trial, 1-to-1, less than 28 weeks, gestational age babies, and IV hydrocortisone was used at 1 milligram per kilogram per day for 7 days, followed by half of that for 3 days, and the outcome was survival without BPD at 36 weeks. The reference is given at the bottom of the screen. And here you can see the results of that study. Survival without BPD was just significant at 60% versus the placebo. There was no difference in the other outcomes, but if you look at the sub-hoc analysis over here, you will notice that if you happen to be a female and if you did not have infection, you obviously had a better outcome. And this is obviously something that you have to keep in mind if you are thinking of using low-dose hydrocortisone. For babies who were given low-dose hydrocortisone, you also had a higher rate of getting extubated, as is shown by the data on top with a p-value of 0.0002, 60% versus 40%. There was no difference in the other adverse events in the babies who got hydrocortisone. Supplemental oxygen was also, weaning off from supplemental oxygen was higher in the hydrocortisone group, and the babies had less amount of PDA ligation in that same group. When they did a little bit of more of a detailed analysis, what they found, essentially, once again, that I want to mention, when they controlled for some of the factors, is again becoming the female, being a female, having less infection and it was more protective. However, there is a risk of increased sepsis in the babies who were given hydrocortisone. So the neurodevelopmental outcome was a follow-up study which was published on 2019 For surviving infants 24 to 25 weeks, they found significant improvement in global neurological assessment in the hydrocortisone compared to the placebo. The risk of moderate to severe NDI of 2% and 8% respectively, no difference in the bigger baby. So the smallest gestational age baby, there was some improvement, and similar risk of moderate to severe NDI of 9% in both the groups. So what about individual patient data analysis, where they compared 5 eligible studies? 4 of them were randomized controlled trials, had individual patient data available. So we are talking about 982 babies that were evaluated. And they looked at early low dose hydrocortisone for 10 to 14 days and significant increase in survival without BPD. However, there are 2 caveats that you have to remember. One is that they did see a significant increase in spontaneous intestinal perforation, especially if you were giving indomethacin, whether as prophylaxis or something for treatment of PDA, for example, prophylaxis for prevention of IVH or treatment of PDA in the first week of life. Also, the babies who got low dose hydrocortisone had increase in the late onset sepsis, which was significant. But in the combined analysis, there was no adverse effects on death or 2-year neurodevelopmental outcomes. Okay, moving on to inhaled steroids. And I will summarize this information at the end, at least to give you the way we handle it, at least in our unit. So if you look at inhaled steroid, it was used budesonide, 2 puffs given for 14 days initially, and then 1 puff every 12 hours till last dose of study drug. And the study drugs were given till the infant no longer required supplemental oxygen or PPV or reached 32 weeks post-menstrual age regardless of respiratory support. And the outcome was the composite outcome of death and BPD at 36 weeks post-menstrual age. If you look at the composite primary outcome, the p-value just hits 0.05. So the odd ratio does not touch 1, so you could say it is significant, 40% versus 46.3%. So while it is significant statistically, I'm not sure I would call it clinically significant that it was protective in that sense. Survival without BPD, with BPD was lower, 27.8 and 38% if you remove the death. But remember that this is not the primary outcome. So this is the separate outcome that they're looking at. This is a little bit of a busy slide, but it basically says that also you'll note that the incidence of PDA was lower in the budesonide group as well as treatment of surgical ligation. So there was that additional benefit too. Reintubation rates were significantly lower in the budesonide group versus the placebo group. And the supplemental oxygen requirement was 0.05. So the other study was the study done in the USA and Taiwan. What they did is the inclusion criteria was within 4 hours of birth, less than 1,500 grams, severe RDS, FiO2 to at least 50%. And the control group only got surfactant. In this study, it was Survanta, while in the study group, they got surfactant plus budesonide, as mentioned there. And it was given as every 8 hours till they were maximum of 6 doses. Primary outcome, once again, was death or BPD. And in this study, they found that BPD or death was significantly lower. This is intratracheal budesonide. Just to clarify, the previous study that I mentioned was through inhaled, but this is intratracheal. And you can see that death or BPD was lower in the babies who got intratracheal budesonide. Severe BPD was also lower. When you looked at their follow-up data, they did not find any significant difference, which means you could argue that it was not harmful. A meta-analysis of 2 clinical trials where intratracheal budesonide has been given with surfactant, they found that budesonide surfactant mixture demonstrated 43% reduction in the risk of BPD with a number needed to treat of 5. Mortality was not different, and a 40% reduction was observed in the composite outcome of death or BPD in the intratracheal budesonide surfactant group with a number needed to treat of 3. So this is very interesting and hopeful, but I think we still need more data to try to see if this is something that should be clinically recommended. One of the other things that I want to highlight is something that has been worked on, which is using CPAP or NIPPV with MIST or LISA, MIST being minimally invasive surfactant therapy or less invasive surfactant therapy using the catheter. So this is a study from Turkey where they compared babies on CPAP versus NIP. using Mr. Lisa, 100 babies in each group. And their primary outcome in this situation was looking at need for invasive ventilation the first 72 hours of life or requiring surfactant. And you can see the babies who were on an IPPV, 13% versus 29%, and for the surfactant, 38% versus 60%. Also, you will see over here that the risk of BPD was lower, was 7% in the NIPPV group versus CPAP of 16%. So this is something that seems to be very, something that's very hopeful. And we are awaiting studies, some recent study that has just been completed. There was also a comparison in the same study from the Turkish study. They actually had a table where they showed between data from other studies that have looked at CPAP versus NIPPV, but they were the only study that have actually combined minimally invasive surfactant therapy, and they showed that it was beneficial when you combine NIPPV with minimally invasive surfactant therapy. Okay, so let me try and summarize what the data that the studies that have been done so far. So I think in terms of the low dose hydrocortisone need to balance benefit versus risk, we don't tend to use low dose hydrocortisone right now because we are focused, like I said, is to keep the baby extubated right from the start. And we will try our very best to keep the baby extubated using the NIPPV strategy. We will use postnatal steroid dexamethasone after 3 to 4 weeks of postnatal life, but that is not very often. So I think in your unit, you'll have to decide whether you're okay with the other, with the risk of late onset sepsis and risk of perforation if you're interested in using low dose hydrocortisone. Inhaled budesonide, while it was initially, the p-values are clinically not, p-values may be statistically significant, but I think there is some concerns, even though it was non-significant, there was a concern about increased mortality in the inhaled budesonide group, and long-term, 2-year confirmed statistically significant increased mortality. Hence, I would not recommend that we use inhaled budesonide with the current data that is available. Now, the steroid and surfactant approach of intratracheal approach, especially say if you can combine it with Ensure, seems promising, but it requires confirmation with a larger sample size study along with the developmental follow-up. The one that I'm most excited about is the use of NIPPV with surfactant using MIST or LISA approach. Additional randomized control trials are needed for this outcome of BPD. And I am aware that Peter Dargaville's study has just been completed, and I do hope in the PAS study, in the PAS Periodic Academic Societies meeting, this will be presented, the data, and will help us decide whether this approach, where you can minimally invasively give surfactant and then switch and keep the baby in NIPPV, it will try and decrease the outcome of BPD and or death. So to summarize, the non-ventilatory approaches or the pharmacological management of BPD, oxygen, again, more than 89%, less than 95% should be a target. Caffeine, please use it. Diuretics, yes, we do use it, but be careful. And if you use long-term, the side effects can be troublesome. Bronchodilators may be helpful in established and most evolving and established BPD. Steroids, be selective in using steroids. And at the moment, I think I would probably only just recommend DART. And I've shown you the data why I would not recommend any of the other ones based on the data that's available. Vitamin A might be helpful, doesn't seem to be any harm. But again, you have to treat about 14 to 17 babies to really get the benefit in prevention of one BPD. What about some other factors besides these drugs that is very important? And sometimes people forget. They're so focused on using these medications that sometimes very other important stuff that we can do to try and at least decrease the risk of BPD. Number one, fluids and electrolytes. Try to keep the baby dry. This has been shown over and over again by different people, analysis, randomized trials, as well as by retrospective analysis. Keep the baby on the dry side. We tend to keep our smallest baby around 80, and then we go up to 140, but avoid sodium in the first few days of life if you can in the TPN or however you're giving the fluids, because that will avoid too much of water to be retained in the body, because you really want the babies to start losing some weight and get rid of the extra water in their body. Nutritional support is extremely important. We actually start with the protein in the TPN right from the birth. So as soon as the baby is born, gets an IV, we will use what we call starter TPN. It has glucose and protein, does not have lipid. We start lipid the next day. We'll start with 3, go up to 3.5, and then 4 grams per kilo per day. With fats, we'll go up to 3. We will start with breast milk, colostrum within 24 hours. And there is some data, not randomized control trials, but there is some data suggesting that breast milk might decrease the risk of BPD. So highly, highly recommended. We have recently established donor breast milk in our unit. And so we use it pretty much for every small baby if the mom's own breast milk are not available. So while we try to keep the fluids on the lower end, we also try to make an effort to increase our caloric intake. And we try to reach around 120 to 140 kilocalories per kilo per day, again, keeping the fluids on the drier side. PDA, we investigate only when we feel that it is clinically significant. We tend to use indomethacin or acetaminophen or Tylenol if we have to close it, if you're not able to extubate the baby. I don't know whether I would say we use 3 courses. Sometimes we only use 1 or 2 courses because now that we have transcatheter closure, the complications of surgical ligation are not really seen with this, and we have some experience, at least in some babies that we have sent for transcatheter closure. So that might be something to think about if the PDA is a problem in your unit. So to summarize, I think oxygen supplementation, keep your saturation between 89 to 94%. And really the nursing effort to keep the nurses involved and very much invested in keeping the saturations. And because till we get the automated loop, FIO2 loop systems in place in all ventilators, I think we have to depend on the nurses to try and keep the oxygen saturation within the range so that we avoid the damage because of high concentration of oxygen. Caffeine obviously helps in keeping the baby extubated. It's been shown to decrease BPD, and we tend to use it as long as the baby is getting respiratory support. Until at least it's more than or equal to 2 liters of nasal cannula, we will use caffeine. Vitamin A, in select cases, we do not routinely use vitamin A in our unit, but obviously in some centers it has been found to be helpful and might be adjunctive therapy. Keep the babies on the restrictive side and definitely focus on providing good nutrition, and especially if you can get breast milk, that would be really great. For the evolving phase, the same as early phase for the oxygen, xanthines, and vitamin A. Steroids, again, we tend to use the DART, and only if we need to try to extubate the baby. Diuretics, usually we start around 2nd or 3rd week of life, but we keep a close eye on the electrolytes and make sure that the baby doesn't get into hyponatremia or hypokalemia. Again, focus a lot on the nutrition. For the established phase, we increase our oxygen saturation targets a little bit higher because we want to try and make sure that the pulmonary vasculature is nicely vasodilated and try to prevent or at least decrease severity of pulmonary hypertension if it's going to happen. Oral prednisone may be useful in weaning oxygen, especially if you're trying to get the baby home and the baby is only on some type of nasal cannula support. Diuretics and beta agonists and anticholinergics can be used. Nutrition is, again, one of the major ways we are able to make the lungs grow. The good thing is the lungs do grow. They grow maximally in the first 2 years of life, but babies do make alveoli even up to 8 to 10 years of life. So if you can provide good nutrition, you might be able to get the lungs to overcome the damage they may have suffered in the first few weeks of life. We obviously highly recommend using RSV and influenza prophylaxis vaccination to avoid the hospital readmission due to lung injury. With that, I'll be happy to take questions during the discussion session. And here are a couple more books and chapters. You can go through them and you will find some very useful information in them. Thank you so much for your attention. Bye.
Thank you very much. So before we move on to the question, we will take a small break of 3 minutes now. So then we will come for the question and answer.
Okay, I would like to ask a question.
We will have a 3 minutes break, doctor.
Okay.
Then start the question and answer.
Vita Biotech's an award-winning nutraceutical company. It is the first nutraceutical company to complete 50 successful years. Well Baby Vitamin D3 Drops is a unique vitamin D3 supplement in an olive oil base. No peanut oil, no castor oil like other formulations. Well Baby Vitamin D3 Drops provides 400 international units of vitamin D3 in 0.5 ml and 800 international units per 1 ml, devoid of any artificial flavors and colors. It contains no artificial sweeteners. Suitable for vegetarians. Suitable from birth onwards. It contains easy to use measuring syringe. Well Baby Vitamin D3 Drops is covered in all insurances including PCP, RN3 and Abu Dhabi Basic Plan. Well Baby Multivitamin Drops is the ideal supplement formula for babies from 1 to 12 months. It contributes to normal cognitive development of babies, supports normal growth and development of bones in babies, helps to boost immunity in babies. It is an appetite enhancer, supports overall health and wellness in babies, contains no artificial colors or sweeteners. Dose: for babies from 1 to 12 months, give 0.5 ml twice daily. Vitabiotics is proud to present the comprehensive multivitamin formula for babies aged 6 months to 4 years, Well Baby Multivitamin Liquid. It contributes to normal cognitive development of children, supports normal growth and development of bones in children, helps to boost immunity in children, provides required nutrients for picky eaters, supports overall health and wellness in children. Dose: for 6 months to 4 years, give 5 ml daily, 1 teaspoonful. Well Kid Omega 3 Chewable Capsules. Vitamin D helps in increasing the immunity. Omega 3 improves concentration and attention span. It builds eye health by improving tear stability, optimizes the brain functions, boosts the synthesis of dopamine that helps in ADHD symptoms, acts as an anti-inflammatory source. The dose is 2 capsules daily for kids aged between 4 to 12.
So we'll move on to the question and answer session. Before that, Dr. Rajiv has an announcement. So then all the panelists will open their cameras and the moderators will take questions one by one. So Dr. Rajiv.
I can't, have you?
Yeah, we can hear you, but start your video, doctor.
Yeah.
Yes, Dr.
I thank everybody for their patient listening, and I watched all the questions coming in. I have requested Dr. Daniel and Dr. Patrick, who are really on service today, to wait for some time. So all those who have questions to Dr. Patrick and Dr. Daniel, please ask now. We will still have with us Dr. Banaclari and Dr. Vineet, who will answer questions as they come. So I request the audience to ask your questions to Dr. Daniel and Dr. Patrick in the beginning, so that they can get back to their service. Thank you.
I have a question for Dr. Daniel, please.
Yes, I cannot, my camera is not working. Apparently, I'm not allowed to use my camera, but oh yeah, okay, great. Can you hear me?
Yes.
First of all,
Okay.
this is Dr. Vidyasagar.
Go ahead.
First of all, congratulations for a very excellent presentation by you and various, all the panel speakers. My question is, you and Dr. Bhandari may answer, if there is a data regarding the cord blood levels of vitamin A and BPD. And second question is, if vitamin, it seems to me among the many therapeutic interventions, vitamin A seems to be very benign. And also, so far your data shows that you need to treat only 14 patients to prevent one BPD. Nevertheless, vitamin A is much more easily available, easily administrable, and why not we really recommend that as a use of vitamin A in all these high-risk patients, babies? That's my question to you and the panel.
So I can answer that question, and then I don't know if Eduardo will be there too. So vitamin A, as you mentioned, it is a fairly benign drug. You have to give IM injection actually based on the original John Tyson's trial 3 times a week for at least 4 weeks. Now, again, you heard Daniel giving a different protocol. Oral vitamin A has been shown by multiple studies done by Ambalwanan, for example, from UAB, that at least the dosing regimen that he used did not seem to be beneficial, but we have to wait for some of the new studies that are working. What I believe, and Dr. Shania, Jayant Shania had written a very nice article on this many, many years ago. The issue is that if you already are if your levels of vitamin A are above a certain level in the neonatal levels, then giving extra vitamin A does not seem to be beneficial. So you are over-treating. It's like if you give surfactant to all babies less than 28, you will be over-treating, giving surfactant to at least 30–40% babies who do not require it at all. So that is the same concept that I'm trying to say. If you have a population, and if you have a population of babies where the maternal vitamin A is low, or you could check it by cord blood levels, if they are low, and Daniel mentioned a level of less than 0.35 microliter, I think, that was there. And if you use that kind of a cutoff and then selectively treat, then I think potentially you will have more benefit. As I mentioned in my talk, if you really look at the data from John Tyson study, there were a lot of babies who were from Texas, Alabama, Mississippi, the southern part of the USA at that time. And that place and there are separate studies that have shown that those areas have maternal undernutrition and low levels of vitamin A. So the benefit that was seen there was probably because of that, because if you remove that population there, the contribution of the babies of southern USA compared to the northeast and Midwest, you may not have seen that benefit. So I think selective or targeted vitamin A in a particular population where there is low levels of vitamin A in the population would be helpful, I think. But then if your levels are okay or normal, then you're just giving IM injections and you're not going to see any benefit.
But I'm talking about a very selective patients who are at risk. And we are not giving a universal treatment, but if we are taking a babies who are less than 28-week gestation who are at risk, so what is the risk of those babies? Do you have any cord levels correlation with the BPD?
I'm not aware of studies where they have actually looked at cord levels and then selectively decided on treatment. But I think in concept, your suggestion is fine. Maybe Daniel can expand, because they are using vitamin A, and I don't know if he has information about the vitamin A levels in their population.
Well, there may be some. I don't have any particular data about that. But then it's also true that I don't actually know how much cord level can be really, reliable in this regard, since later when you start ATP and you start, feeding and so on, and you may have different requirements from different babies according to gestational age, according to the alveolar situation and so on. Maybe it would be better to say blood level of vitamin A in the first 3 days of life or something like that. I don't know. That's a good question. It's a matter of discussion. Regarding the schedule, you're right, Vinet. Majority of studies the studies that have been meta-analyzed were on 3 shots per week, 5,000 units per shot. We decided to do 15 in just 1 shot because there was an additional study comparing the 2 administration which actually seemed to show that there was no difference. And the total dose was the thing that influenced the outcome more. Then there is one thing I want to highlight, because somebody said that it's a number needed to treat of 14. Again, this actually depends on the type of BPD you have. It actually depends on the incidence of BPD in your population. That's mathematics. You see the paper of Barbara Schmidt recently published in Journal of Pediatrics. The number needed to treat can be lower or can be higher according to the outcome incidence.
Can I say something? Dr. Patrick wanted to go early, so a couple of questions for him because he's attending and he has message to leave early. So there's one question about BPD related pulmonary hypertension. Do you have separate criteria to diagnose that, Patrick?
So that's a great question. So let me try to kind of talk a little bit in more detail. I think one of the most fundamental problems we have in contemporary care of this patient population is that our starting point is babies get BPD, then they get pulmonary vascular disease, then they get pulmonary hypertension. That may not be correct. I think it's important to recognize that, you know, what may lead to dysregulation of pulmonary vascular bed and what may lead to kind of impaired alveologenesis and so forth may have different pathways and may be presenting at different time points. And this becomes very, very relevant for the infants at the most extremes of prematurity. Our traditional thinking is we make a diagnosis of BPD at 36 weeks and then we screen for pulmonary hypertension. And reality is that there are many babies that have early pulmonary vascular disease, early pulmonary hypertension, that may not necessarily keep pace with what we would traditionally think of as BPD. So I think number one, there's the assessment of pulmonary hypertension, but number two, there's the radar at which point that we think about it. So we don't start our screening for pulmonary hypertension at 36 weeks. We actually started in babies either 36 weeks or 8 weeks postnatal age, whichever comes earlier. So, you know, and if you think about it, infants that are 22 or 23 weeks, you're forcing them to wait 14 weeks to have their first evaluation for chronic pulmonary hypertension when they're probably the patients at the highest risk. So, so there's the optimal time of screening. And then the second part of it that becomes incredibly relevant is that a lot of the tools that people use to evaluate chronic pulmonary hypertension are based on subjective assessment. Does the right heart look dilation? Does the septum look flat? Is there some evidence of RV dysfunction? And kind of we know from kind of reliability studies that kind of the kappa coefficient for these things can be incredibly low. So point number one, I think we need to screen earlier. Point number two, I think when we screen, we need to look more comprehensively at, there are other additional measurements that you can use to quantify pulmonary vascular resistance, assess RV function, and so forth. And then the third part is, and I think I alluded to this earlier on, is that not all BPD or BPD-associated pulmonary hypertension is related to pulmonary vascular resistance. Screening out infants that have systemic hypertension with pulmonary venous hypertension, who potentially need a very, very different approach to treatment is one thing. And then secondly, infants that may have shunt physiology, as we talked about earlier, in particular the ASD phenotype, may also present in a BPD-looking pattern. So I think, you know, if you think about it, you know, and I'm making this intentionally sound complicated because neonatal cardiovascular physiology is not simple. And I think the days of saying BPD equals you're dependent on oxygen or you're dependent on mechanical ventilation at 36 weeks is probably too simplistic. And we need to look within that patient population at what are the specific phenotypes. Is it isolated lung phenotype, lung plus pulmonary hypertension, or lung plus systemic hypertension? And then try to strategize how can you modulate each of these entities in their own unique sense. So those are my thoughts.
The same baby could fluctuate between these as well.
Oh, well, the same baby may fluctuate, but for example, you know, if you make a diagnosis of pulmonary hypertension and start the patient on nitric oxide, but the patient actually has got systemic hypertension with pulmonary venous disease with LV diastolic function, nitric oxide is not going to help that patient. You're going to make that patient worse. So, and I think this is where trials of prophylactic use as a chronic therapy have failed, because they have not differentiated the patient populations. And I think, you know, if we ever get back to looking at trials of low dose nitric oxide, I think it's going to be very important to try to tease out truly the sub-patient population that have true pulmonary vascular disease with BPD.
Thank you. I mean, extending the same question, there is a question on sildenafil use. So I suppose the same answer applies, that you have to choose the patient correctly.
Yeah, and again, we use sildenafil, and again, our selection of pulmonary vasodilators is normally done after, obviously, one, you want to do whatever you can to optimize the lung, make sure you're ventilating the patient well, and make sure you're taking good care of nutrition. And if you truly have pulmonary hypertension, obviously, you know, the approach to therapy really is going to depend on, you know, what are the ambient features. So we would typically use things like inhaled epoprostenol, we may use sildenafil or low-dose nitric oxide for certain patients. Or in other patients, if there's a lot of systemic hypertension, we may think about bosentan as the provide therapy for those patients. So yeah, so kind of very much individual approach based on what is the physiology, and then reevaluation, and again, not forgetting that there's a small patient population that may masquerade as BPD pulmonary hypertension, but they have pulmonary vein stenosis. And I think having a radar for that, screening for that, and if the clinical course is not going as planned, thinking about the role of cardiac catheterization.
Thank you. Just one final question.
One more question for Dr. Patrick.
Yeah.
I have also two questions for Dr. Patrick. Go ahead, Monica, you go ahead first.
Okay. It is by Pooja. She's saying like 24, 26, 28 week with moderate PDA, and baby is on conservative management, given unable to extubate at 2 weeks, and you gave Tylenol twice. When to close now the PDA, and as longer duration of PDA flow, increased BPD risk, you said, leading to PPHN. So
okay, so again, it's I think everything is in duration of exposure. I think, you know, again, going back to one adjudication of that the problem is truly a problem, that this is a pathological left to right shunt, and this is not, say, lung disease with pulmonary hypertension, I think is the first thing to do. And assuming that, yes, you are managing a high volume PDA shunt, obviously our approach, as mentioned, you know, we do a targeted approach in the first few days of life. And if by day 7 the shunt is a problem, then we will use indomethacin. Obviously, other places may choose to use oral ibuprofen, which seems to be effective in inducing PDA closure. But one of the things that really there's not a lot of literature on, and Vinny talked a little bit about numbers of courses of therapy. I think one of the things that I think, again, with comprehensive evaluation and looking more detail at markers of shunt significance helps you differentiate, did that course of therapy do anything? Because, you know, if you've given a course of whether it's indomethacin or Tylenol or whatever, and biologically the ductus remains open and none of the physiologic markers have changed, it's very hard to justify based on logic why you would give the same therapy again if it's not worked the first time, and you truly think that the shunt is a problem. Then obviously one potentially would proceed towards some form of intervention. So most of our patients end up getting device closure somewhere around 2 to 3 weeks. We have not proceeded earlier than that. There is a trial currently under planning called the pivotal trial, which is looking at percutaneous device closure between day 7 to day 14 versus a conservative arm. So that may provide additional information. So bottom line for deciding about surgical ligation, number one, do you have a problem? Is the shunt a problem? And I think if it is, I think you can proceed to some form of interventional closure. I think, like has been mentioned by other speakers, the experience with device closure is much more positive than surgical closure, but it's not completely benign. Some of these babies may still get post-closure respiratory instability from high left ventricular pressures. And then you may have kind of device complications that can occur as well.
Okay. Patrick, I have two questions. One is regarding the prophylactic use of any medicine for closure of PDA. And the other thing is that one of the participants asked about that you said in your talk that Tylenol act by vasoconstriction, okay, and it can cause pulmonary hypertension. So it is contradicting in a way that it can cause the pulmonary hypertension. So
okay, that's a great question. So again, I think it's important to, so let me take the second one first. We'll talk about Tylenol. So remember, so the effect that we know on potentially the mechanism is through some pulmonary vasoconstriction. Now, remember, pressure is the composite of flow multiplied by resistance. So although you may get some pulmonary vasoconstriction, by actually decreasing the ductal shunt, you're decreasing the magnitude of flow to the lung, so your pressure doesn't necessarily rise. Now, if you have a patient that has confirmed pulmonary hypertension on echo, you should not be closing the duct. Okay, so that's the first thing. But certainly our experience with IV Tylenol in the first 48 hours of life, we have never had to stop it because of a pulmonary hypertensive crisis. And the same logic applies with nitric oxide. And a lot of people are misguided that nitric oxide decreases pressure. Nitric oxide decreases resistance, okay? Yes. And by decreasing resistance, flow will improve. So acutely, when you look at babies, nitric oxide responders, and you echo them 1 to 2 hours later, they still have pulmonary hypertension, okay? But their improvement in oxygenation is as a result of an improvement in flow as your resistance falls. So I think the answer to the question about Tylenol is exactly the same as within the medicine. Make sure you're not closing the duct in someone with pulmonary hypertension. Sure. If the patient does not have pulmonary hypertension, it will be well tolerated. And certainly we've had very, very positive experience with it.
There's one more question for Patrick before he goes, that you recommend early PDA closure based on scoring criteria. Is it a medicine or the surgical ligation? Is there any difference between the two in terms of short-term or the long-term outcome?
Okay, so again, the selection criteria is the identification of shunts that are problematic, progressive, based on comprehensive assessment, not just on the basis of size. So we select out these babies that already have major signs of altered QPQS. Medical therapy, so we use Tylenol. I would not recommend any form of interventional closure in the first week of life, particularly because the changes in loading conditions, obviously one, the preterm myocardium doesn't tolerate kind of major changes in loading conditions, but certainly the last, and it's a long time ago since I've seen this, but I remember in Toronto, there was, when I arrived there were a couple of babies that had PDA ligation in the first 3 days of life, both developed severe post-closure interventricular hemorrhage. So I would not surgically close the duct in the first 3 days.
Okay. Can I ask one more question to Patrick?
Yeah, sure.
Yeah, sure. Just one quick one. What is the range for low dose nitric oxide? Is there a range or you give a specific number?
Okay, so again, this is not based on, I don't have a randomized trial or a big study to quote, but again, you go back and you look at the trials of low-dose prophylactic nitric oxide or any form of nitric oxide given chronically, the selection of babies that may have, say, PDA physiology or maybe even heart dysfunction, LV dysfunction, or particularly LV diastolic dysfunction, was not precise. So echo was not used to identify patients based on risk profile. What we do is if we identify and confirm in a baby with severe BPD, and again, these mostly are 22, 23 weekers. I fully agree. Bigger babies, you get them extubated. 22, 23 weekers, you extubate them early at your peril. You know, they typically end up being re-intubated quickly after being exposed to a lot of kind of high oxygen requirements. So those babies, again, assuming we've managed the ductus, we're managing everything else well. If there are signs of early pulmonary hypertension or pulmonary vascular disease, I may use low-dose nitric oxide, 5 parts per million for 2 weeks as a steroid-like of therapy. And we've had some real good success with that in getting babies extubated. But again, this is not a randomized trial. This is a specific practice that we use based on physiology and close monitoring.
Thank you.
Okay, so can we move to Dr. Ben-Kalari, or because I have a lot of questions for him. Is okay, Rajiv?
Okay with me.
Yeah.
Yes. Okay, Dr. Ben-Kalari, welcome back. So there are a couple of questions about the definition, the physiological and the clinical definition of the BPD, because there are old study in 2014 where Dr. Walsh said that if you look at the clinical, it shows higher as compared to the physiological. So can you kindly comment on that?
Yeah, so one of the limitations of most definitions of BPD is that we are using oxygen, that is the therapy for hypoxemia in this case, to define the disease. So that's the first problem. The second problem is that until a few years ago, before Barbara Walsh described the physiologic definition, different units had different ways of giving oxygen. Some units were keeping babies with saturations of 80, 85. Others wanted to have the babies with saturations over 95. So obviously that contaminated the definition tremendously. And there were huge differences from one institution to the other, not because the babies were different, but because people were using oxygen with different criteria. Now, today, I think most of us are using a pretty strict range for oxygenation. Okay, VNIT may use 88 as the lower range, we use 90, that doesn't make any big difference. And the high end, that is where really most of the mistakes were done, nobody uses at this point more than 94, 95%. So I think today, most units in the world are doing physiologic administration of oxygen to all babies. So at this point, if you see all the data from the NIH network, the latest data, there is no difference between physiologic and clinical definition, because essentially all units are giving oxygen based on an oxygen target that is very similar.
Okay.
So I don't think we have to worry about that today.
Sure. Thank you. The other question about, this is the era of calculators. Do you have a comment on the BPD calculator? It is validated or not?
This is for prediction of BPD.
Exactly.
Yes. Yeah, there is a lot of literature on prediction of BPD, and I think it's interesting data, but I personally think that it's kind of useless. Mm-hmm. Okay, the best predictor of BPD is gestational age and the severity of the respiratory failure. All of you neonatologists know right away when a baby is born at 23 weeks and he's requiring 50, 60% oxygen on a ventilator, you know that that baby has a very high risk of BPD. Yeah. And the best predictor is keep your statistics and compare that baby to your population. All these risk calculators, some of them are based on several units. The NIH obviously is the network, but again, the network is different from your experience in the United Arab Emirates, and it may be different from European units. Yeah. So I think that there is a value, but I don't think that for parent advising are very helpful. I don't think for research are very helpful. If you want to include a population that is at high risk, again, you just select the babies that are less mature and with more severe RDF at the beginning. So I think it's a nice exercise, and every year there are 2 or 3 papers with prediction of BPD. Yeah. I don't know what we do with that data.
So the hot question for you is this one, that why you are not using volume targeted ventilation?
Okay, yeah, I'm sorry I didn't have time during the presentation to explain that. And I have to say, we are doing volume targeted ventilation. Our therapists, our physicians are at the bedside, our nurses, and they are constantly looking what tidal volume is the baby getting. And if the tidal volume is too small, they will adjust the peak inspiratory pressure. If the tidal volume is too high, they will reduce the peak inspiratory pressure. So we are doing targeted ventilation, volume targeted ventilation. What we don't do is we don't give the responsibility to the ventilator to do that, because although it's very convenient for the staff, because you don't worry about it, because the ventilator will adjust the pressures automatically, we find, and we have used different ventilators. Actually, we helped Draeger develop volume targeted ventilation. So we were all vested on that technique because we feel it makes a lot of sense, because it wins quicker, it may prevent over distension and so on, but it's a very tricky technique. I always give the example, is the same thing as what happened with the Boeing 737 MAX. You are giving the responsibility to a volume sensor, to a flow sensor, okay? Same as if that volume sensor or flow sensor is given the right value, the ventilator will make the right adjustment. If that sensor gives the wrong value, the ventilator will do the wrong adjustments. And unfortunately, flow sensors in a ventilator circuit with secretions, surfactant, blood, humidity, very frequently fail. And the ventilators recognize crash, big failures, but small differences, the ventilator doesn't have any idea, and they just take the value that they are getting from there. So that's problem number one, equipment. Problem number two, what tidal volume do you use?
Yeah.
4, 5, 6. Each baby needs a different tidal volume at different stages of their evolution. Using a fixed tidal volume doesn't make any sense. And what happens is that if you use a tidal volume that is slightly below what the baby needs, the baby will struggle. The baby will essentially start breathing over because the ventilator is winning when it's not supposed to win. And the opposite is also true. If you are using a tidal volume that is excessive, what will happen? The baby will just quit. He will not breathe at all. And the ventilator will take over, something that we don't think is a good idea. So we use volume targeted ventilation for babies who are extremely unstable to stabilize their tidal volume, babies who have frequent hypoxemic episodes. But routinely for everybody, we don't think that is a technique that is sufficiently developed at this stage to recommend it routinely.
Okay. So
can I add something on that?
Sure.
I can only concur with Eduardo. I couldn't agree more. And on top of that, all the let's say the rumors on volume guarantee and this type of thing beyond the commercial pressure behind are also due to the fact that there are meta-analyses showing that sort of a volume control is beneficial, but they mix everything. They mix a volume guarantee from one type of machine with another volume guarantee using a different software with ventilators on volume targeted, which is again another techniques. So this is like, bananas and apple in the same meta-analysis, and it's not very. We only use volume guarantee during the very short time during the insure, because you inject surfactant, compliance is gonna change pretty quickly. So for 10 or 15 minutes, we place them on volume guarantee just during the insure procedure, and that's it.
I have a question.
Yeah.
Go
ahead. Go ahead.
One question, Dr. Daniel. I am very interested in lung ultrasound, Dr. Daniel. I was going to use it for my new edition of the book. So the question is, what do you do for those who don't meet your lung ultrasound score? I'm very impressed with this lung ultrasound thing. It has to be a standard of care in all the units. Dr. Daniel.
So again, if you think about the lung ultrasound score at the birth, this is very easy. There is a very nice threshold from our studies, but also from others. There is a meta-analysis that has been published in archives 1.5 years ago, and another one we did for neonatology. So lung ultrasound score beyond 6 or 8 predict the need for surfactant very, very accurately. Then there is the prediction of BPD later on. If you look at the lung with lung ultrasound serially. So let's say at day 7 or day 14. This is also, there are data about that. These are also very much significantly accurate to predict BPD. Then I can echo Eduardo again, because we are in a situation where, okay, we can predict BPD, beautiful. And with lung ultrasound, you can even see the lung, how it's doing, and you can, see how it's doing every day or every week and so on. But unfortunately, we are in a situation where we can see that, but we don't have any weapon for the BPD. Okay, you see it's not doing well. What are you gonna do? What is the drug you're gonna give to the baby? There is actually no perfect drug for that. So ideally, especially now we have something that is repeatable, non-invasive, and easy to use a lung ultrasound, I would say that if we're gonna have a beautiful drug for BPD, doesn't matter if IGF-1 or any other, I don't know, hopefully one day we're gonna have it, you can maybe select population also using a lung ultrasound. Otherwise, the usefulness for BPD or lung ultrasound explicitly resides in the titration of mechanical ventilation. This is something very useful, because if you want to do your alveolar recruitment, it doesn't matter if it's non-invasive or in volume guarantee or in high frequency or whatever, you can see the effect of your alveolar recruitment at bedside in a few seconds with lung ultrasound. And this is why we do that while using the aggressive non-invasive protocol that I showed you. There are other techniques to visualize the effect of the alveolar recruitment, but unfortunately they are not point of care, they're not at the bedside, and especially thinking about electrical impedance tomography, it's not marketed and it's much more difficult and blah, blah, blah. So.
Because Daniel, I wanted to ask you, this lung ultrasound should be a standard of care in the bedside when you're optimizing lung volume. And the genesis of BPD lies in the optimizing lung volume at all points in time. So lung ultrasound and artificial intelligence, they'll be able to fine tune this every hour or every half an hour.
I think we are mixing two things. BPD is not lung volume. BPD is much more complex than that. Surely in babies that are evolving towards BPD, we can see that is a worse lung aeration, that's for sure. But the discriminatory power of lung ultrasound, let's say the precision of visualization of lung ultrasound does not go in such details to allow you to see alveolarization, okay? You only see the loss of lung aeration. This is what you see. It may be, it is actually associated with the development of BPD. We published that in the Blue Journal, but it's much more useful and sensitive in the acute phase of respiratory failure. And it doesn't matter if it's RDS or ARDS or meconium aspiration or pneumonia or whatever. Then it's very much useful, because all these acute respiratory failures are basically loss of lung volume, while BPD is also arrested alveolarization and so on. So when you say it should be standard of care, I totally agree. I couldn't agree more. And I can tell you that in this regard, neonatology is very much delayed, because if you look at the literature in adult critical care, it is standard of care in adult critical care. The first guidelines, evidence-based for the use of lung ultrasound in adult ICU dates back of more than like 15 years ago. We proposed the first one last year. So there is a delay of at least 10 years, more or less.
Very good. I'm very impressed with the technology.
Okay. I have a couple of more questions for Dr. Ben-Clary before he goes. Dr. Ben-Clary, the early versus late caffeine, what do you think about that, and the use of caffeine in the delivery room?
Okay, I'm glad that the question came up. And I could talk about this for a couple of hours, but I will try to answer in a couple of minutes.
Okay.
Caffeine is a great drug to treat apnea and to extubate patients. It has never been shown that it's a drug that prevents BPD. Never. There is no paper in the literature. The paper that triggered all this was the CAP trial that Dr. Barbara Schmidt initiated to see if caffeine was safe. her concern was caffeine was doing a lot of brain damage because there is a huge amount of animal literature showing that caffeine in high doses and in certain circumstances can produce brain damage. So the CAP trial was great. It showed that caffeine does not produce, I don't think that it showed that protects the brain, but it clearly showed that it doesn't increase the risk. That study did not have BPD as one of the main endpoints. In fact, the population that was included in that trial was babies that were going to be extubated within the first 10 days. Who is going to do a study to evaluate BPD and include that population? So that's number one. Number two, that trial, the control group, was a under control group because those babies did not get caffeine for apnea or for extubation. That was an indication that had been already proven to be effective. So you are comparing caffeine with absence of caffeine, complete absence of caffeine. And that's clearly not what I'm proposing. Caffeine should be used for extubation and for apnea because there is clear evidence for that. Now, there were several retrospective analyses, including the CAP trial, showing that babies who got caffeine early did better than late. So everybody, all the neonatologists in the world now are saying, so we have to start caffeine, giving coffee to the mother, and then a dose immediately after the baby is born. There is absolutely no evidence from good prospective randomized trials showing that early caffeine in babies who are ventilated makes any difference. In fact, the results I showed, that is the largest retrospective trial from the pediatrics group here in the US, didn't show any effect. The only prospective randomized trial is a pilot study that we started, only 80 patients, because the OSMB, the review panel, told us to stop the trial because there was increased mortality in the babies who were getting early caffeine during the first 3 days. Too small numbers, that's why I didn't even mention it. I don't want to implicate that caffeine will increase mortality, but certainly in our study, there was no benefit at all in babies who get caffeine the first 3 days from those who get caffeine at the time of extubation and for apnea of prematurity that are the classic indications. So our feeling in our unit is that there is absolutely no reason to start a drug that can have serious side effects. And you can see some publications from the group in Harvard showing increased cerebellar hemorrhage with high doses of caffeine and alterations also in tone at 2 days of age, at 2 years of age in these patients. So caffeine is not a benign drug. It's not water. It has effects on practically every cell, and at high doses can produce significant side effects. So our position on that is we do where we know that there is pretty good evidence that helps. We don't think that there is evidence, again, to use it to prevent BPD from the first day of life.
Okay. Last question from my side. The surfactant use. If the baby cannot be intubated and develop the BPD or the late surfactant use, it might help, or is any study about that?
Yes, Roberta Ballard was the PI in a study to evaluate the effect of surfactant with nitric oxide combined in babies who were stuck on a ventilator to try to see if that would improve lung function and help reducing BPD. The results were not clear, and certainly they did not confirm their hypothesis that this could help. And unfortunately, again, the intervention was combined with nitric oxide. That is something that I don't think is justified either, to give nitric oxide for long periods of time to all these babies.
Then
Okay,
one question to Dr.
Yes.
Vineet. Dr. Vineet, one question to you. How you have already answered this. When do we start vitamin E? At what age? You already classified, Dr. Vineet. You told the vitamin A within the first.
When we used to use it in one of my previous this thing, I don't use it in the unit right now because, like I said, we just don't see it being beneficial because our population we think has adequate amount of vitamin A levels. but when we were doing it based on Dr. Tyson's study in NEJM way back in the 1980s, I believe it was published. So that was starting at birth for the first 3 times a week for the first 4 weeks and using 5,000 international units. So that was the dosing that we had done, yeah.
Can I say something about vitamin A?
Yeah, sure, Dr. Go ahead.
Again, vitamin A is one of the few drugs where there is evidence, more than one randomized trial, prospective randomized trial, well conducted. And the thing is that we are not giving vitamin A as a drug that will improve alveolarization or decrease inflammation. We are giving vitamin A to prevent deficiency that is known to occur in babies that are not getting sufficient vitamin A. So the reason, again, to use it is in babies who are not feeding, who are getting only parenteral nutrition, where the vitamin A that we add is inactivated by light and adheres to the plastic. So the amount of vitamin A that these babies are getting while they are not feeding is insufficient. And there is lots of data showing that the vitamin A levels can be normal at birth, but with time, over weeks, if the baby doesn't get additional vitamin A, they get vitamin A deficient. And that is one of the factors that has been shown to impair alveolarization. So the idea of vitamin A, again, is to prevent the development of A deficiency. If you are able to measure in your lab, I think that that's great, because then you can initiate the therapy with a known low level. If you cannot measure vitamin A, again, the data from all the studies showed that the vitamin A levels drop if you are not giving additional vitamin A. Now, there is a question, I think, also there, whether you can give it orally. And yes, Dr. Chennai and in Vanderbilt, he showed that using vitamin A orally is also absorbed. Not as well, obviously, as the parenteral product, but it can be absorbed to a certain level and maintain vitamin A levels better. So it is an alternative.
Okay. So other panelists have other questions to Dr. Bankalavi?
1 minute for Vineet, one question. Vineet, I wanted to ask you regarding this vitamin A we answered. Then do you treat all ureaplasma infections is one question to you.
Yeah, so we don't routinely detect ureaplasma because part of the reason it's not that easy to detect, and unless you have PCRs. So we did try to do a study earlier on where we tried to detect, and as you know, ureaplasma only comes from the mother, so you can't get it from the sink or from your environment. And if you look at the data, and again, the group in University of Maryland had done some very nice work. They've been sitting on the edge. So they've tried azithromycin, they've tried so many different approaches, but the data is not strong enough for at least us to routinely screen and then treat, because we're not really sure that even if you treat it, if it makes a difference or not. The way I look at ureaplasma is that if you are a preterm baby and you're sitting on the edge of getting BPD or not getting BPD, and you get an inflammation secondary to ureaplasma, which is a low-grade inflammation, that might tip you towards getting the baby getting BPD. So it is at that point, we look at babies less than 28 weeks that I worry about it. I will tell you, my maximum effort in these babies is, first of all, get rid of the tube. That is like my major focus. Get rid of the tube, keep the oxygen under control, provide good nutrition, and then hopefully that'll be fine. I don't know many places that routinely do ureaplasma, checking if the baby is intubated and then treat if it's positive. I can tell you that and as has been shown by the studies done by the University of Maryland group, if you treat all babies by erythromycin, that trial did not show a benefit in decreasing BPD. So treating all babies and with or without, you test it, but you don't get the results quickly enough, and they treat it, and that has not been shown to decrease BPD.
Okay.
So I
yes,
think we've answered most of the questions today. I think we've answered.
Yeah, I think we whatever I have the list of questions, mine and the participant which sent it to me, we gave it already. So
Dr. Vidyasagar has some questions.
Yeah, Dr.
question.
Dr. Vidyasagar has some question.
Yes. Okay. Go ahead.
Just a question to Eduardo. What does the crystal ball tell us in 2030? Will you be discussing a BPD still?
Unfortunately,
Yes.
I think so, because again, as I mentioned before, the original BPD was preventable because it was a sort of iatrogenia. We were inducing it. The present BPD is a problem of development that doesn't only affect to the lung, but there is every day more and more evidence that all the organs in an extremely low birth weight infant are not developing the way they are supposed to develop. And there is a paper published in just a few days ago, or weeks ago, showing that these kids, when they reach early adult age, have much higher mortality. And mortality not only because of lung disease, but because of cardiovascular issues and a number of other problems. So I think that as long as we have extreme preterm infants being born and surviving, unfortunately, I think that probably we will be seeing and realizing a increased number of sequelae rather than reduction. So the only reason why my answer would be no is if our colleagues in obstetrics develop a strategy to eliminate preterm births, and in that case, all neonatologists will be obsolete and we will not have to worry about anything because most of our practice is around the extreme premature infant. Those are the kids who have issues.
Yeah, we had a lot of hopes with the surfactant thinking we'll cut down the BPD. It did not happen. We thought of antenatal steroids. It's not happened. So I think we are reaching a limit of our expertise or science to have a preterm baby well-developed lungs.
So actually the two examples that you mentioned are excellent because antenatal steroids and surfactant are probably the most effective drugs in neonatology in the last 40 years. They have improved survival dramatically, but all the complications associated with extreme premature infants have increased because of that, because we have a larger population that is susceptible to these complications. So I think that the only answer really is prevent prematurity or have a artificial placenta and uterus that is so fantastic that imitates what happens in utero and allows these babies then to develop into full term normally. And I think that that is I don't know, I don't think will be in 2030. That will take a long time.
One last question.
Raji will continue 2:30.
No, I won't. This last question to Vineet. What is the BPD rate in your unit?
So, our chronic lung disease, using the WAN definition, we have BBs less than 1,500. We are on the high side right now in the new unit that I am in right now. So here we have somewhere between 35 to 40%. So it's on the high side and I have to work on, we don't have the proper tools to get it down. But I can tell you, for example, when I was at Yale, when I came there, we had a BPD rate around 40%, and then we targeted non-invasive ventilation, decreased infections, and targeted the oxygen saturation. And by the time I left there in 2015, we had gone down to 19%. So right now I'm working, because this is a new unit and I've only been here for a year, I'll need some time to try to get this thing turned around. Yeah, but it's high right now in my unit right now at Cooper.
Today, I thank you for a beautiful session, and we have answered all the questions. We have lived up to the expectation of all the people. A good response have come in. So I will ask Dr. Jayasheela to say a vote of thanks to the excellent CME we had today. It was so educative, informative, illustrative, and interactive. In all the 4 areas, we have scored 100%, which is very unusual. So I call upon Jayasheela to give the vote of thanks.
I would like to thank Dr. Rajiv for bringing such great people to us and helping us and enlightening us towards care of these little babies. And like we all know Dr. Vidyasagar since our undergraduate days from Downey's Core, and like to see all together in this CME is such a big thing for many of us, youngsters like us. And thank you all for helping us in the journey towards taking care of these little babies. and helping us to improve their survival. And by survival, we just wish that these strategies will help us to give them an intact survival. That's it. And thank you so much, all of you.
Thank you very much, all of you. A great CME we had. It will be historical, Dr. Sagar, like 25 years back. This will be a historical CME to be compared off and on. Thank you so much.
Congratulations.
Thank you, thank you, thank you.
Thank you. Bye-bye.
Thank you very much and congratulations.
Bye, Eduardo. Bye, Rajiv.
Thank you all
Bye
the
bye, everybody.
Bye-bye. Great seeing you.
Keep safe.
Yeah. A word to the audience. So this program was accredited with 4.5 CME points from UAE Ministry of Health. So the certificate will be delivered to your email within 1 week, inshallah. Okay. Until then,
Thank you, Tawfiq, for arranging everything.
Thank you, Tawfiq, for arranging such a fantastic time-bound CME. You have almost become a doctor. In fact, all the doctors asked, "Are you a doctor?" So we will give you a certificate as a doctor with 100 CME points.
Rajiv, it looks like there are maximum number of attendees were at one time 589. Maybe perhaps you can distribute them by region later on and send us information. It will be very interesting.
The attendees were around 1,000. There were 1,000 attendees.
No, and when I was looking at the participants here, they were showing 500. Maybe they did not register properly.
No, we saw 1,000 today.
Okay, good, very good.
1,000 people. So I
Very
thank everybody, Dr. Patrick, Dr. Vidyasagar, Dr. Eduardo, and Dr. Daniel, and Dr. Vineet for such an excellent CME, which will be a landmark CME, which we can be compared in the next few years, I think. Thank you all. Good day. Good night. Thank you.
Thank you. Thank you.
Right.
Good night.
Thank you, Tawfiq.
Night.
Thank you.